So let's briefly just chat about Breakwater, another like phenomenal win for our patients. Really exciting to see before we move on to ctDNA and adjuvant. So maybe obviously I'll start with you, Scott. I think like life's work in this space, and I mean, like congratulations to the community for this amazing
and for giving patients hope.
Yeah, I think to like it was. I mean, the gasp in the room,
yeah.
right? I think
yeah.
30 months for like BRAF V600E patients is incredible, and I think maybe talk us through a little bit about the study design and why did it make such a big difference when we gave it first?
Right. Yeah, it's a really fascinating. So the study was looking at standard chemotherapy or the combination of FOLFOX and encorafenib cetuximab. There was a kind of EC alone, encorafenib cetuximab alone arm that wasn't part of the primary endpoint. And that really seen that doubling in overall survival when you bring encorafenib cetuximab in combination with FOLFOX in the first line. Even though, a good proportion of patients got the BRAF EGFR inhibition in subsequent lines in the control arm, right? So this really was a bit of to the best you could probably do with a BRAF population, really was a kind of a treatment sequence, right? And just showing that it was together. So it's a fascinating biology, and I think we're learning more about it. Part of it is that a lot of the mechanisms of resistance to chemo and to targeted therapies are not the same, and that when you combine them, you can constrain the different ways that a tumor can develop resistance. And we think it's just by narrowing down those escape mechanisms that we're able to really get this durability. But I will say it surprised me. I mean, I thought it was going to be positive, but when you saw the magnitude, you were like, oh my goodness, this is really, really impressive.
Yeah, and I mean, sorry, Cathy.
I was just going to say, do you want to just mention real quick about the FOLFIRI arm so people are aware?
Yeah, so the FOLFIRI, there was another cohort that we'll be reading out later that is asking the same question with a FOLFIRI backbone versus standard of care, so that's coming. And then the other arm that I mentioned that was reported out was the EC arm alone, so chemotherapy free. It did not, its survival was numerically better than the standard of care, but under the FOLFOX EC arm, and so really suggesting that this is a reasonable regimen for patients who may not be great chemotherapy candidates. Again, our elderly elderly patients that are more likely to have BRAF.
Yeah, so maybe let's just talk about a couple of practical things that are going to come up now. So we talked about the biomarker testing at the beginning, and we all recognize how sick patients that had the BRAF V600E, and again, just highlighting the fact that this V600E is the alteration. There are other BRAF mutations too. And maybe in the MSI high patients, you feel comfortable waiting a few weeks for your biomarker testing before you start IO. But in a patient that's sort of walking in the door, you sort of suspect that this may have a BRAF mutation. You don't have the testing back. Should you wait? Should you start? Is it okay to start chemo and then just add in the encorafenib cetuximab, and I think help the listeners here kind of feel reassured that. I think my take home was even if you don't have the test, start the FOLFOX and then add it in, but don't wait until 3 months later when you're getting restaging scans, or 2 months later. But
well, I think first of all, the beauty of ctDNA to try to get those results to us earlier. That turnaround hopefully throughout, and not only at our institutions, hopefully can be like 7 to 10 days, if not earlier. And so really, I think by the time you get a chemo spot, hopefully you'll have that data. But if not, okay to start the FOLFOX. I just had this literally last week. I started the FOLFOX, didn't want to wait. We all assumed it was BRAF, just added the EncoCetux afterwards. And I think what's important to tell the community is don't wait. Like you said, if you find the BRAF, you've already started the FOLFOX, add it and then, restage afterwards, because we really see what the difference is between first line and, incorporating it second line. So.
Yeah, and I think, I had similar. I started FOLFOX. It was a young patient. I had a sense and lots of disease, and actually started FOLFOXIRI, and then came back and just took off the irinotecan and added it in too. So I think to Scott's important point there is even like we again, and your point, it was we saw, like, we don't want people to leave here as saying you still have the Beacon data, right? We have encorafenib and cetux as second-line data, but again, 30 months when you do it early with chemotherapy. So, and any, sorry, Stacey, you're
I
going
was
to
just
say
going to
something.
ask, so Scott, so we quote 29, 30 months from 80405 for all comers. So do you think, like, does this fix BRAF?
Yeah, I mean, it is, you're right, it's...
Not better than RAS.
Yeah, so
Better than a
so there
standard
were,
right-sided patient.
where there was this kind of discussion is that, reflecting back to, when HER2 amplified breast cancer, right, used to be the worst subtype, the most aggressive subtype. And I think we still have a ways to go until we can claim we're like the progress made in HER2 amplified breast cancer. But I thought it was an interesting analogy, like if we really understand the biology and we really are developing drugs in an intelligent way, could we get to the point where what we thought we knew about the biology can be flipped?
And any, I think we all are big centers, and so we see a lot of patients, but it's still a rare subset. And so for the listeners, any just advice on like side effects that are coming up and how you manage? I think there's a lot of this fear of the rash, but actually the rash may not be as bad as cetuximab rash is, and so just love some thoughts on how you manage toxicity with the regimen.
I mean, I think all of the colon cancer providers feel pretty comfortable taking care of rash at this point relative to some of the other malignancies that have to address a rash. So I think we're pretty confident. Just be proactive and make sure your patient is aware to take the medications. Don't wait for the rash to get to a certain level of toxicity, and make sure they wear sunscreen. That's always a big thing as well, due to the hypersensitivity of the sun. So.
And I would say maybe dose reduction rather than just stopping.
Definitely.
Too,
Once again, communicating is key.
Yeah. And it's really low rates. I mean, the rate of grade 3 or higher rash is almost non-existent, right? So there is this, and this has been seen in a few different settings where, BRAF and EGFR rash is less than, we saw that in Beacon. And I don't know, Christine, if you want to mention even the topical BRAF as an example, right, that you've been involved in.
It's interesting, right, because now Lutris has a topical BRAF, and so we've been trying to, for the anti-EGFR patients, non-Beacon, non-BRAF, the rash is pretty bad, right? So now trying to understand how we can improve this. So actually there's a BRAF inhibitor cream for these patients, and it's actually helping improve the rash quite a bit, much more profoundly than the standard antibiotic or the hydrocortisone creams that can kind of be an antibiotic-sparing kind of regimen. So I think very promising in that sense. So I agree with Scott. I mean, we really, because of that mechanism, I think we're not really seeing much rash in the BRAF patients, which is very nice. The last thing they need is a rash.
Exactly.
And I had a patient who was on Capox for first-line known BRAF when the data was released and kind of had the go-ahead that we could do it. And I switched her to FOLFOX and encorafenib cetuximab. And really, I mean, we had serial scans and it showed a much more impressive response. And she was very nervous about starting, with this new therapy and potentially more toxicities, but it went very well. And I think probably if it better controls the cancer, then the toxicity is manageable. But what had come up that I messaged you about, Scott, is maintenance. So, you start and you're, guns blazing and you go in with everything, but we know oxaliplatin still has toxicity. So are you, for your patients, are you stopping the oxaliplatin at a certain time, or are you waiting until they have neuropathy?
Yeah, I think managing similar to, how we do otherwise, and trying to anticipate a little bit, not always successful, but we try to, to get on that sooner and stop it. But I think, for the maintenance question, the data and the study was continuation of the 5FU, and I think that's an important point. Yeah. So when we really shouldn't change that part of our maintenance strategy, and the biology really is such that probably it's that continued synergy of the 5FU and the encorafenib cetuximab is maybe part of the reason that we get the durability that we get.
It's beautiful that we can even talk about going on maintenance for these BRAF patients, right?
Yeah, and I think so many questions now. I think, revisiting, there was Rona, a friend of ours, all had the adjuvant trial, so now, should we really need to revisit the role of adjuvant BRAF and, and then surgical patients to perioperative therapy for these patients. So really, really exciting.
But keeping in mind that these were all MSS patients.
That was you read my mind. So the last question I was going to go on to before we move on to finishing with ctDNA is, as you just mentioned, there's an overlap, right, of BRAF patients and patients with MSI high disease, and we're awaiting first-line, CMARC data with the combination of encorafenib and cetuximab and PD-1 inhibitors. But until we have that data, if you have a patient that has both, what's prioritized? What do you do?
Immunotherapy.
Yeah.
I mean, that's where the cures are.
100%
Yeah.
agree.
Yeah, and I think that's just a really important point to kind of drive home, is that I think currently immunotherapy is still the way to go for these patients. Any final, leave you the last words for BRAF?
Yeah, no, I mean, it just gets back to our comments at the beginning, like test and no, and that it's really not sequential therapy is not going to get you to the same place.